Hello, my name is Terry Cunningham, and I'm the president of the Liver Coalition of San Diego. Welcome to another informational seminar dealing with liver disease. We have experts providing very useful information. The Liver Coalition was founded last year to fill the void created during the early days of the pandemic. Now, all funds raised stay in San Diego and do not go to a national organization. Please look at our website for other webinars and more information that will be very useful to you. I'd like to take a moment to thank our sponsors. And the first sponsor that we have is AbbVie, and they have a video for us. And I'd like to thank them for their support and also thank Dynavax for their support. And next we have SI, and Chris Boyd is going to talk about one of the drugs that they have.
Thank you, Terry. Thank you for having me. This is my first Liver Coalition talk, so thank you again. My name is Chris Boyd. I'm with ASI Oncology. I help promote our drug Lenvima, which can help patients with unresectable HCC. And so I'm based in Temecula, and we have a short video here to show you Lenvima and how it could perhaps help liver cancer patients.
Thank you very much, Chris. I'd also like to thank Gilead for funding this seminar. We couldn't do these without our sponsors, and so we're very pleased that they are helping us with this series that we're doing. And now I'd like to introduce Shirley Sonoda, who is the Associate Medical Advisory Council Chair. Shirley?
Thank you, Terry. Welcome everybody to our liver webinar on cirrhosis and complications in primary care. And I'd like to introduce Dr. Deanna Oliver from the Southern California Liver and GI Centers. If you have any questions, you can put them in the question box that is off to your right, or you can, and I will have Dr. Oliver answer them at the end of the presentation. Dr. Oliver?
Thank you so much, Shirley. 1 second here, I'll just share my screen. Okay, my name's Dr. Oliver. I'm a hepatologist with Southern California GI Liver Centers. I have a special interest in our cirrhotic patients as well as our decompensated cirrhotic patients in the hospital, and also like to focus on palliative care for patients with end-stage liver disease. Our agenda for today is to kind of go over the natural history of cirrhosis, the clinical course of cirrhosis, and the complications that we see in cirrhosis, and briefly just talk about transplantation, which is the goal for a lot of our patients with end-stage liver disease. So first, we'll talk a little bit about the natural history of cirrhosis. So this is what our normal liver looks like. As you can see, it's nice and smooth around the edges. You can't see any scarring. A lot of times we're hearing the phrase nodules in the liver. So in this liver, we don't see any of that fibrosis or scarring, no nodules, and the surface of the liver is very smooth. That's in contrast to how a cirrhotic liver looks. You can see this irregular surface, and this is often what you'll see in your ultrasound reports or CT scan reports, where they'll say an irregular contour, irregular surface. Sometimes they're going to comment on the nodules, and the other arrow that's not labeled, this is the scarring that you see inside the liver, that's classic for a cirrhotic liver. Really, how does the liver fibrogenesis or the fibrosis occur in the liver? So first we start with our normal liver. Whatever insult is causing the inflammation, whether it's a viral hepatitis, alcohol, non-alcoholic fatty liver, various different metabolic disorders, this creates the chronic inflammation that occurs in the liver. And from this, we end up with the scarring, the fibrosis. There's multiple different ideas behind how we then end up with hepatocellular carcinoma or cancer. But initially, it all starts from that chronic inflammation from the various insults that are occurring on the liver. So really, when I think about cirrhosis, I think about it in stages and prognostic stages. That's what our patients always want to know, especially in the primary care clinic when they first get diagnosed with cirrhosis. A frequent question that I get is, well, how much of my liver is working? And what happens is the patient has chronic liver disease from whatever reason. We find they have cirrhosis oftentimes on an ultrasound, long before they present with decompensated cirrhosis. Now, this is the category of patients that you're going to encounter in the primary care office. And that patient's always asking, well, how long do I have to live? How much liver do I have left? And we'll go through those kind of concepts, and I'll give you some data about where patients land once they have compensated cirrhosis versus decompensated cirrhosis. Now, what's really the difference between compensated and decompensated? I like to explain it to my patients in a simple way. And I tell them, when you have compensated cirrhosis, you can walk around town. Nobody has any idea you have liver disease. Whereas once you have decompensated cirrhosis, oftentimes you're having things where people know that, oh, this person has a liver problem, usually because of the yellowing of the skin or the jaundice, the yellowing in the eyes, and the acidic fluid in the stomach. Those are the most obvious reasons that someone has liver disease. And this is kind of the differentiating between my compensated and decompensated cirrhotic. And ultimately, once a patient has decompensated cirrhosis, then unfortunately, without liver transplant, then they'll die from their liver disease. So where do these complications of cirrhosis come from? Once we have cirrhosis, we end up with portal hypertension. That's what's going to cause our variceal hemorrhage, the ascites formation, the edema in the lower legs. Sometimes patients also get an effusion in the lung called hepatic hydrothorax. Most oftentimes that fluid in the lung is on the right side, but not always. Sometimes can be both sides, but more rarely would it be just a left-sided fluid. Most common, like 80% of the time, the entire right lung gets filled up because of this. And then the liver insufficiency aspect is what causes our hepatic encephalopathy, what causes our jaundice. The liver is just not filtering how it's supposed to. It's not making the blood products that it needs to make. And that's kind of the two categories of how we end up with these complications from cirrhosis. Now, what we definitely know is that once a patient has cirrhosis, their survival is significantly impacted. If you look at some of the older studies with hepatitis C, if patients didn't have cirrhosis, their 11-year survival was much better than the patients with cirrhosis. And if we look at even the non-alcoholic fatty liver patients, it's the same category, but a little bit different. If you see the non-alcoholic steatohepatitis, even the patients in stage 2 and 3, the mortality is a little bit worse, but the cirrhotic patients much worse. Most likely because the patients with non-alcoholic fatty liver tend to have combined metabolic syndrome. So they have diabetes, heart disease, other problems that they aren't necessarily dying from their liver, but they could be dying from stroke, complications from their diabetes, or renal failure, because these patients frequently also have diabetes and heart disease. And then when we look at the compensated cirrhotic versus the decompensated cirrhotic, this kind of gives us an idea when that patient asks us our question, well, how long am I going to live like this? You know, I have cirrhosis. You know, this week already I must have been asked 4 times, does that mean I'm going to die tomorrow? And I always tell the patient, no, you know, it ranges. I wish I had a ability to tell you how long, you know, before the liver gets worse. But we have patients, you know, that have been living for 20 years with cirrhosis, doing just fine, who are not going to probably die from their liver, but from some other reason. But around 12 years is kind of that median with a pretty large range. This is obviously dependent on if we can get rid of whatever was causing the injury. So if they have hepatitis C, curing their hepatitis C. If they have active hepatitis B, giving them medication to stop the hepatitis B from replicating and damaging the liver. Alcohol, obviously, to stop drinking. And some of the other rare diseases, we do have some various treatments for, but are a little bit more difficult to stop that progression. And then for fatty liver, obviously working on the diabetes, weight loss, getting their liver enzymes back into a normal range, getting the fat out of the liver. You know, this is the key to keep the liver from progressing faster than it would if it didn't have those complications. Now, once a patient starts having decompensated cirrhosis without transplantation, then the median survival is about 2 years. So what's our clinical course of cirrhosis? So kind of like we talked about earlier, we have these patients who we call compensated state. We kind of break this up into 5 different stages with that line in the middle where we really start to see the difference between compensated and decompensated. Patients who we can't really see that they have a liver disease versus the ones who we can clearly tell have a liver disease. So a lot of our patients, when they're first diagnosed, are in this stage 1 category. It's really important that they get referred in order to get an endoscopy to make sure they don't have any esophageal varices, because even without ascites or jaundice or any of these other things that we see, we want to make sure we're managing the esophageal varices, because bleeding from esophageal varices has a very high mortality rate. And then we head into the stage 3 and 4. As the portal hypertension gets worse, we start to develop things like ascites, worsening hepatic encephalopathy, bleeding, and really these patients become symptomatic, and we're seeing frequently in the office for their complications. Ultimately, the patients in stage 3 and 4 end with what we are now calling acute on chronic liver failure. So these are patients who have chronic liver failure and have some acute episode that occurs, And those are the patients that are coming into the hospital who either one, need a transplant or have to have significant treatment in the hospital to get them back out of the hospital. Now, kind of the annual rate, the progression of cirrhosis, about 4% per year getting cancer, 6% are becoming decompensated, and around 4% death rate for patients with cirrhosis. And again, the outcome that none of us want is when the patient gets hepatocellular carcinoma. Again, they start with this normal liver, whatever injury that's occurring leads them to cirrhosis. They start getting nodules, and then there's a lot of different possibilities as to why the cancer's occurring, but routine screening is really key. Either referring the patient to a hepatologist, or if the patient's very compensated and the primary care feels comfortable, then doing screening every 6 months with an ultrasound and an alpha-fetoprotein is standard of care for any patient with cirrhosis. And keeping in mind, those patients with hepatitis B can develop cirrhosis at any stage of liver disease, and they need to be screened every 6 months as well, regardless of the status of their liver disease. Let's go a little bit into the complications of cirrhosis. I organized a few different case studies to kind of make it a little more interesting. So the first one that I feel is noticed by the primary care group would be thrombocytopenia. Anytime a patient has low platelet counts, we really need to work it up. Anytime we meet a patient for the first time in our primary care office, talking about their alcohol history, drug history, screening those patients with diabetes for fatty liver and NASH is really important. And especially because a lot of times the liver enzymes are not different from anyone else, but the platelets can be kind of our cue into that the patient has some sort of liver issue. So the first case, a 47-year-old male with decompensated alcoholic cirrhosis presented to the clinic after a recent admission for bleeding esophageal varices with banding. When he went into the hospital, his hemoglobin was 5.2, his platelets were 32, INR 1.3, and total bilirubin was 1.2. During his procedure, he required 6 bands. He was transfused packed red blood cells and platelets. And the plan for him after discharge is to have repeat EGD, which is routine, to see if any further banding needs to occur. He had repeat EGD with platelet transfusions and had an allergic reaction. And he told you, I never want to have this procedure again, but obviously this patient needs to have more endoscopy until we can eradicate the esophageal varices with banding procedure. So how common is thrombocytopenia in our chronic liver disease patient? About 70% of patients actually have thrombocytopenia. Again, it's a big clue into a patient that has some liver disease. This worsens over time with the portal hypertension and the worsening of the liver disease. Sometimes the patients, they don't want to do surgeries on or any diagnostic treatments because of the thrombocytopenia, and they do have an increased risk of mortality and poor outcomes. So why does thrombocytopenia occur in our liver patient? It's multifactorial, like most things, but the splenic sequestration due to the portal hypertension is the common reason, along with obviously these patients can have direct bone marrow suppression. There's also some antiplatelet antibodies that can cause destruction. Just the sheer stress of the platelets going through the organs and decreased production of thrombopoietin or TPO by the liver actually causes adds to the splenic sequestration from the portal hypertension. So what are our treatment options? We look back at this gentleman who had a reaction to platelets and doesn't want to do any more procedures. Really, in general, we're not using platelet transfusion anymore in our liver patients. We are starting to use thrombopoietin agonists. Basically, we work by mimicking the effect of the thrombopoietin to increase the platelet production. There are multiple different versions of this. Some of them work quickly within a few days. Some of them take a few weeks. So a patient who has a really low platelets, usually less than 20, we will elect to use the thrombopoietin agonist in order to do various procedures, or if they're having active bleeding, to help them with this process. When they did studies on the thrombopoietin agonist, it actually showed much less bleeding after procedures, less need for transfusion after procedures, and anytime we can decrease the transfusions, especially in liver patients, this is always a benefit. So I would say this is much more widely used, especially in patients who we need to do procedures on who have really low platelets. Probably the most common thing you're going to encounter and the biggest complaint we're going to get from patients is the ascites and the lower extremity edema. So let's talk about a patient. She's a 55-year-old lady on the transplant list, hasn't had any alcohol for 10 years, and she comes to clinic with worsening ascites and minimal lower extremity edema. Her labs from the week before are showing creatinine of 1.2, her sodium's a little bit low, her bilirubin's elevated, her liver enzymes a little elevated. Before this, her creatinine was, 0.8. She'd had a paracentesis done 3 days prior in the ER, and that was her 5th paracentesis in the past 4 months. Keep in mind, for someone like this, we need to make sure that we're giving them diuretics with an appropriate ratio. So if we're going to give furosemide 20 milligrams, that goes with spironolactone 50 milligrams. If we're going to give furosemide 40 milligrams, then we're going to put this with spironolactone 100 milligrams. Sometimes patients, I would say like 3 to 4% of them, experience significant breast tenderness with the spironolactone. And in this case, although not as good, we can use eplerenone. The biggest problem with diuretics is the risk of acute kidney injury and decompensation, dehydration leading to patients coming in for hepatic encephalopathy, and of course the risks of electrolyte disturbances. So what happened with this lady? She comes into the hospital twice with acute kidney injury after increasing her diuretics. In the hospital, she's received repeat paracentesis. At this point, with her 6th or 7th paracentesis, diuretics maximized, causing acute kidney injury 2 times, we would consider this patient refractory to have refractory ascites, and she's not diuretic tolerant. And for this patient, really our only choice is to do a TIPS procedure. Now, a TIPS procedure comes with its own complications, but obviously we can't remove fluids from a patient every few weeks. Sometimes I get referrals where a patient's getting paracentesis, weekly. They set them up on a schedule. The problem with this is every time we're taking fluid out, we're taking a lot of protein out. The patient's nutrition status gets much, much worse. And then they become more difficult to qualify for transplantation because of their nutritional status. So for me, when I'm seeing a patient, if I'm getting to the point where I'm at monthly or maybe every 3-week paracentesis, I can't increase my diuretics. Now the patient needs to be considered for a TIPS procedure, which, as we all know, are not without risk. Technically, the interventional radiologist is very good at this point. So technically, we don't run into a lot of issues. But the biggest complication of the TIPS is hepatic encephalopathy, because we're shunting a lot of the toxins past the liver, and what filtration the liver was doing is no longer getting done. So this is a pretty common thing where this lady, after her TIPS does well, she goes home. We're able to stop all the diuretics. She's doing better. Her quality of life's better. The discomfort from the significant ascites is gone. But she comes back to the hospital within a week or 2 with hepatic encephalopathy, and we have to titrate the medications as well. Okay. So what is the TIPS? Basically, it's connecting our portal vein to the hepatic vein, bypassing a portion of the blood not going through the liver. And by doing this, the backup of the blood is less, and we end with less ascites. Esophageal varices will go away. And so this procedure is used in a few instances, one being for refractory ascites and the other being for recurrent bleeding from esophageal varices that cannot be stopped with banding. So esophageal varices, definitely, once a patient has varices, their risk of decompensation goes up significantly, as well as their risk of death. So you can see in the cirrhotics and the patients with esophageal varices, there's a huge difference in the path to decompensation. If you look at the difference in the 15 years, patients with no varices versus patients with varices, you see a big difference not only in decompensation, but as well as liver-related deaths. So this is why when we think back to those earlier tables where we said, oh, there's patients walking around who are compensated, they have cirrhosis, but they have 0 symptoms, but those patients could have esophageal varices, and those patients are the ones that we need to make sure get their screening endoscopy to see if they have any varices, because if they do have varices, their risks for decompensation, their risk for liver-related death are much, much higher than the patient who has no varices. So anytime a patient is diagnosed with cirrhosis, even if they're compensated, they need referral for endoscopy to check for the esophageal varices. Obviously, routine screening is required. Now, if I have a compensated patient who we do the screening on, no varices, then I can repeat that endoscopy in 2 to 3 years, unless they have a new decompensation. If they develop ascites, they develop more hepatic encephalopathy, then we would take a look earlier than that, 2 to 3 years. If a patient has minimal or trace, then we tend to repeat in 1 year. And if a patient requires banding, then we keep repeating the endoscopy until we eradicate the esophageal varices. We also use the non-selective beta blockers as a primary prevention for bleeding. This is in specific populations, so depending on the size of the varices depends on whether or not we're going to use beta blockers. Traditionally, people had used propranolol, but now in general we're using carvedilol. And then obviously for the esophageal varices that we cannot resolve with banding, or if a patient has a repeat bleeding episode, then the only treatment for these would be the TIPS procedure. So now we can talk a little bit about hepatic encephalopathy. So we'll talk about a patient, a 56-year-old lady with NASH cirrhosis who had found out she had cirrhosis about 4 years prior to her presentation, came to the hospital with melena and hematemesis. She became confused on the way to the ER and eventually became unresponsive in the hospital. These would kind of be the common lab values you're going to see in a patient like this. Her hemoglobin dropped from her baseline. Her platelets are low. She has some coagulopathy with an elevated INR. Her ammonia level is high at 108. Bilirubin elevated, and her MELD score, which we'll talk about a little bit later, is elevated at 19. And oftentimes in these patients, you're going to see an elevated BUN and creatinine because of the bleeding. And she has a little bit low albumin, which is all consistent with her cirrhosis. So this lady gets an endoscopy with banding. Her bleeding stops. She started on lactulose. Unfortunately, didn't tolerate it well, had excessive diarrhea, and the dose had to be adjusted, and she was given rifaximin as well. And the plan for this patient was follow up in 1 week after discharge. And of course, like all plans, sometimes they don't go as we expected when a patient gets discharged from the hospital. 9 days later, she comes back, obtunded, grade 3 hepatic encephalopathy. She had only been taking her lactulose and did not get her rifaximin because of the high copay. She had not seen her primary care or her hepatologist after discharge. I would say this is the most common problem for hepatic encephalopathy after discharge. is that the patient does not get a quick enough appointment, and the hospital did not organize rifaximin on discharge. With the different hospitals I work at, we have a pretty good system with the case managers, but it's well known that rifaximin has a very high copay, but there are a lot of patient assistance programs, and knowing this is very important that we get the prior authorization. But I wish I could say every hospital is organizing it before the patient leaves. Unfortunately, I would say they did some studies, and about 60% of the patients, when they left after hepatic encephalopathy admission, did not go home on the medications that would have prevented them from coming back, a week or two later. So this is a huge barrier for these patients. Now, something that people always are talking about is ammonia. Now, ammonia is something that we order, but it definitely doesn't add much diagnostic or prognostic value for patients with hepatic encephalopathy. And really, I always say, well, if the ammonia is normal and the patient's in a coma, they probably have hepatic encephalopathy. But if the patient's doing great and the ammonia is a little elevated, then they have this what we call subclinical encephalopathy. So the value is helpful in the grand scheme of all the values, but we will know that ammonia is not the only factor causing hepatic encephalopathy. There's a lot of other neurotoxins that have been investigated, but it is something that is checked usually at admission, but trending the ammonia doesn't necessarily correlate with how the patient's doing. What are our treatment options? Really, the only treatment options that we use these days are lactulose and rifaximin or Xifaxan. Lactulose is our first treatment of choice, and rifaximin is an add-on, especially for patients with recurrent hepatic encephalopathy and recurrent admissions to the hospital, or in patients who cannot tolerate lactulose. Another complication, obviously, of cirrhosis is hepatocellular carcinoma. Unfortunately, this year with the COVID pandemic, we've seen a lot of patients coming with advanced stages of cancer, either lost to follow-up or didn't get their routine tests, or, of course, there are patients who hadn't been diagnosed with cirrhosis, and their first diagnosis, we find out they have hepatocellular carcinoma. So it's really important, if you're going to keep the cirrhotic patient in your office and not refer them out, that you're doing ultrasound and alpha-fetoprotein every 6 months. I do recommend early referral to a hepatologist for any patient with cirrhosis, more so just for this reason, because this is our main focus, to get that screening for the esophageal varices and the screening for the hepatocellular carcinoma. Because once a patient has hepatocellular carcinoma, we want to catch this early, much easier for us to treat, and the patient can then get a transplant because they now have cancer. Keep in mind of our special population, the hepatitis B patients, and they need to have screening every 6 months regardless of their stage of liver disease. And the other patients, we're only screening cirrhotics. In that population, we're going to be screening everyone, no matter their stage of liver disease, because they can develop cancer at any time. Our treatment for hepatocellular carcinoma at this point, depending on the size, we have a lot of cooperative work with our interventional radiologist for the TACE, ablation, Y90, as well as followed with immune modulators. In our group, we've done some studies about the immune modulators and the significant improvement in recurrence. And then obviously, once a patient has developed cancer, the ideal timeline is to get them when the cancer is small so that we can kill the cancer, put them into remission, utilize the immune modulators, and then we get them worked up for transplant. Because once a patient develops cancer once, they're highly likely within the next year or two to have another cancer develop. And sometimes after we are able to get rid of the first cancer, that next cancer can come more quickly, and then the cancer can get bigger faster. And then we're in the position that the patient no longer qualifies for transplantation because the mass is too large or because the cancer could have spread to other parts of the body. So once a patient has cancer, they've had intervention, we're screening them every 3 months with MRI in order to capture any changes at an earlier time frame. The last thing I wanted to talk about was briefly transplantation. Now, the old kind of category that we utilized for transplantation was a CTP score. We still talk about the CTP score because it does differentiate patients in a kind of a nice way, whereas the MELD score just gives us a number. So I like to tell my patients in the clinic, you know, you're cirrhotic, you know, I can't give you a percentage, but you're either an A, a B, or a C. An A is our compensated patients, and you can stay like this for many years as long as we're able to stop the injury to the liver. And then the B and the C are patients that are decompensated. And the way we work, you know, come up with this number is basically encephalopathy and ascites. Now, the reason why we no longer use this for transplantation is because obviously encephalopathy and ascites are very subjective by the physician who's grading. So, you know, differentiating and giving patients higher score between different providers is obviously a problem. Because two of the values were the physician just saying, oh, it's recurrent or precipitant or controlled or refractory. And so it's not a very good scoring system. But you can kind of see the compensated patient, they're going to have an INR less than 1.7. They're going to have a bilirubin less than 2. And their albumin's going to still look good. It's going to be above 3.5. When we head into the more decompensated patient, you can start to see that their coagulopathy is getting worse, their bilirubin is getting worse, and the albumin is starting to come down. Now, the MELD score is the current system that we're using to allocate organs. Initially, we used the bilirubin, the prothrombin, and the creatinine, or the INR, and the etiology of liver disease, and that has now been dropped and replaced with the patient's sodium and whether or not the patient is on dialysis. So a patient who's really compensated, all the numbers are looking good, they're going to have a MELD score in the low category, like 6 to 9. In patients that are getting transplanted, then that score is going to be between 30 and 40. In general, in our area for transplantation, we're transplanting patients usually between 28 and 32 to 34, and that's kind of the scoring system, the score level that we're transplanting in our area. Now, obviously, what does this mean? It means that the sickest patient gets the liver first. Whereas in the old system, it had to do with how many years you were on the list. So this is a more fair system that someone who doesn't maybe need the liver or ever needed the liver could have gotten a transplant before just because they've been on the list for so long. Whereas now it's more fair system based on laboratory values, and those laboratory values are adjusted for the sickest population to get the transplant first. Obviously, this is more fair for lots of reasons. Socioeconomic involved, not every patient has the same access to a healthcare provider to get them referred to a transplant center, to get on the list, to be on the list longer. So regardless of, you know, the socioeconomic status or how often you've seen the doctor, once you get into the right hands and you get referred, your MELD score is your med score, and each day the list will change. So whoever's at the top of the list that day would get the transplant in that region. This was developed back in the early 2000s, late 90s, to kind of give an idea of what the 3-month mortality is in patients. So these are patients who are in the hospital. So as you can see, when a patient has a MELD score between 30 and 39. Their 3-month mortality is 83%, and even between 20 and 29, 76%. So those are the patients who are getting transplant because their 3-month mortality is very significant. When the MELD score is going over 40, this is almost 100% mortality without a liver transplantation. Again, these transplants are occurring at higher MELD. In general, the rule of thumb that we like to utilize is that we refer the patient to a transplant center when their MELD goes over 20 to 24. That's when it's time to refer to the transplant center, or any MELD when a patient has cancer. When a patient has cancer, this changes their MELD score. So even if they're very well compensated and they have a low MELD score, once they have HCC, we know that their life expectancy is decreased. We know that the cancer is going to come back again and recur. And so in those cases, they actually get extra points in order to get a transplant sooner, because otherwise they may be doing very well. Okay. Thank you so much. Obviously each one of these complications of cirrhosis can be broken down into a separate talk, but I hope that I was able to give you a little bit of overview of the various complications of liver disease in the primary care office. In general, you're going to see the patient. You're the first person who diagnoses the patient, usually from an ultrasound or because you noticed that their platelets were low. And the key thing I want everyone to remember is screening for cancer, because this is life-saving, and then referring to your local hepatologist at the earliest time you can. I don't think there's any wrong time to refer in any cirrhotic patients. Thank you so much.
Thank you so much, Dr. Oliver, for that nice overview of cirrhosis. I was just wondering if there are patients or caregivers listening to this presentation, if you could give us an idea of the types of signs and symptoms they should look out for when the patient is transitioning from compensated to decompensated.
Sure, I would say in general, there's those obvious signs that people are going to notice, right? The yellowing of the eyes, or more fluid in the belly, more fluid in the legs. But probably in the beginning, people start to notice the hepaticencephalopathy, kind of this subclinical encephalopathy where you're thinking, oh, they're kind of repeating themselves a little bit. They didn't used to do that. Or they told me they got lost on the way to the grocery store. Okay, this is a common thing that'll happen, that the patient who's never had an issue getting anywhere all of a sudden pulls over on the side of the road saying, like, I'm not sure how to get to the grocery store. I'm not sure how to get home. We actually did study a long time ago, a driving study in patients with cirrhosis, and the amount of cirrhotic patients who couldn't remember the street, it was an actual machine where they drove in a clinical research study, and the amount of patients was higher than you would ever have expected, that had to go one path to the grocery store and couldn't remember the path to come back to the house. Okay, and then if people start having a little issue with dealing with their banking, this is another thing, or their writing isn't quite the same as it used to be. Those are those really subtle things that you see, like, oh, when they sign their name, it doesn't look like it used to. Then we know that there's some decompensation going on, some of this hepaticencephalopathy that you wouldn't notice just talking to somebody, but if you're living with somebody, you're going to see those little teeny things that you just feel aren't making sense. And that might be especially time to make sure if they haven't been sent to a hepatologist that they get sent to a hepatologist.
Wonderful. That was perfect. And then one final question. What do patients, caregivers, and even primary care physicians, how do they go about referring a patient for liver transplant?
Sure. So, in San Diego area, we have a few different places. Sometimes the primary care is referring to the local gastroenterologist as the first step. Some gastroenterologists feel comfortable with the cirrhotic patients that are in the early stages. Oftentimes, like in my area, the gastroenterologist, once they see the patient decompensated, then they send them to the hepatologist. So they'll take care of them up until that point where they become decompensated. And then that's when they send them to the hepatologist in order for the hepatologist to decide, do they need liver transplant evaluation? In general, I would say, in San Diego, we have UCSD, we have Scripps, and then we have our group that's a private practice. And we partner with both of the transplant centers once our patients are ready for referral for transplant. And depending on various insurances, we even work with USC as well, based on what the insurance plan approves. So we're a little bit unique because we're not associated with any one specific transplant center, but no matter where the patient gets to, eventually, if they're decompensated, they need to get to a transplant center.
And is that usually done then through a hepatologist? So would you suggest that patients and caregivers make sure to plug into a hepatologist if they feel their liver disease patient needs potential referral?
So definitely, getting into a gastroenterologist who defines themselves as a hepatologist is the key to making sure you're on the right path to get the appropriate referral.
Wonderful. Okay, well, I think that wraps it up for our webinar tonight. I want to thank you again so much, Dr. Oliver, for your wonderful summary of cirrhosis. And that will close our webinar for tonight.
Great.
Thank you all for coming.